This is a talk. Please excuse me walking around. I sort of like to pretend I'm a TED talker. My daughter's here. She loves TED, and she said I was complaining. I had 180 slides for this talk, and she said you can't show 180 slides in 20 minutes. My wife said just show one slide per year. You've got 20 minutes, and 20 years it should be easy. So Lauren just said, try and make it interesting. So I'm trying to make it interesting. Hopefully I won't embarrass her too much. So looking back on 20 years of PET at Peter Mac. And so 20 years ago, I was foolish enough to be the convener of another meeting. It took me 20 years to get over the trauma to try and organise one. And this is me 20 years ago as the convener of the ANZ S&M meeting, which we organised through 1996 to 1997. And we had a formal dinner. And I got dressed up in my tuxedo and bow tie, and my eldest son said, "Dad, are things going so bad you have to be the waiter at your own meeting?" We were at your service. It seems sort of scarcely believable to me that it was 20 years ago we put in our first PET scanner. And we look back, we made many mistakes as we went along, but we did perhaps the best we could at the time. We have to remember that all of this began about 40 years ago, and the guy looking over the shoulder of Abbas Alavi there is my mentor and Rich's mentor at the University of Michigan, Dave Kuhl, who really set up the whole area of PET in terms of starting FDG imaging. And Abbas did the first PET scan, and that's between the two old guys there. It really showed up the brain and the heart, and they were the first two applications of PET scanning in the world. They really led the way. This was in fact the first oncologic PET scan that I saw. I went to the University of Michigan to study the metabolism of the heart, cardiac PET, and Rich did this study. And in those days, a PET scanner could only look at that much of the body. And so he took patients who had advanced breast cancer because you could find it, you could feel it, you could put it in the field of view. And this was the first one I saw. And that was a real revelation to me because you saw, firstly, heterogeneity in the tumour, an area of necrosis that wasn't otherwise apparent. There was an internal mammary node, there was an axillary node, and there was a bone metastasis that were completely unrecognised. And Rich eventually wrote this up in Radiology in 1991. For me, oncology applications of PET were proven with that one case. That made, for me, the case for PET in oncology and really changed the direction of my career. Not everyone listened. The game changer, as far as I was concerned, and I was making my way with Marcus Schweiger as an expert in cardiac imaging with PET, and one of the many predictions that I've made that were wrong was that clinical PET would be a winner in cardiology. It should be, but still not. But the thing that changed the game was this picture on the front cover of the Journal of Nuclear Medicine that showed that you could do whole body imaging for the first time. A fabulous change. And that inspired me to go out on a limb, as it were, to really push for oncologic PET to be a clinical tool. And one of the people who led the way, for me at least, was Peter Volk, who had one of the first whole body capable PET scanners. And he showed in this really seminal work, should have been published in the major journal, even Nature, I reckon. He showed that clinical efficacy was the ability to change management. That's what's important about imaging, if you can direct and more appropriately influence management. He recognised very early on the cost effectiveness was vital for clinical acceptance, and because of that, he engaged physician advocates, and I have a group that I call the Trojan Horse Club, which are clinicians who've written a paper on PET in their own journal, their own specialty. They're a great group of people, very large group of people here at Peter Mac. He recognised the importance of also engaging with the people who pay for scans, because they make the rules. So with this information, we reckoned that the times were changing, the climate was changing, but like the poor little mammal across the front there, a few of the dinosaurs thought we were rather crazy. And we were lunatics. Most of us thought, most of the people thought we were insane, thinking that what had been a research modality could possibly ever be a clinical tool. Didn't think it was possible. But we thought, if we looked at the 5 pillars of personalised medicine, obviously we can't do much about preventing cancer, but we can do a lot about predicting how a cancer is going to behave. We can assess the extent of disease more accurately to plan the treatments that are best for a patient. We can preview very early on, and Rich showed this in 1991, that you can see metabolic response way before you get shrinkage of a tumour. And post-treatment surveillance, after a patient's been treated and they've still got a lump there, we can tell whether it's viable or not. And PET's like the lifeline that underpins it. We knew that from a very early stage, but we had to go out and prove it to other people. We had to go and find out the data to support that. When I started this program in 1996, as I said, most people thought I was crazy, and the president of our society at the time, Jeff Bauer, saw me at the annual meeting and he said, "I hear you're putting in PET." And I again, made a rather bold claim. I said, if PET isn't the future of nuclear medicine, it has no future. And those in the audience who know Jeff will realise his response is rather typical. He said, "I used to think you're a smart guy, but now I know you're an effing idiot." Nevertheless, we pushed ahead. We didn't have much money. In fact, I encouraged GE to give us a PET scanner, and they did. All we had to do was buy one of their MRI scanners, because they were trying to sell their PET business at the time. They didn't think they'd make any money. And I said, you won't sell the company for any less if you give us a PET scanner when we buy the MRI, and they did. So they gave us one on 5 years free, lease free, or capital free, with the agreement if we didn't make it work, we'd give it back after 5 years, or else we'd buy it at the depreciated value. It was a very good scanner for our purposes because it was cheap, it had high sensitivity, high throughput, but it had some limitations. This is the PET team in 1996 when we began. Me, 2 fabulous techs, David Binns, who's here, and Megan Suter. I don't know if Megan's here. She was my cardiac technologist. I ran the program by doing nuclear cardiology on one side of the corridor that made enough money to support the PET program on the other. So no patients paid for PET scans. And because I was paying for them, I could choose who got them. And that meant that all the clinicians had to justify why they were going to get use. We didn't know if it was going to work. We took a lot of risks, and we thought that it would probably work. And we did 5 or 6, sometimes 7 patients a day, which at the time was one of the busiest PET centres in the world. But it was also rather lazy time for me. I used to go for a run every lunchtime. I was very fit at that time, so that's me at lunchtime, going off with my headphones to practice French, listen to the French on my iPod. All of this was made possible by having a couple of fantastic supporters. John Morris was our CEO, a nuclear physicist by training, so he was really excited. And when we went looking in the old site for a place to put the PET scanner, there was an old bunker that was used for cobalt. And I walked down and there was some rooms next to it, and I said, "This is where the PET scanner is going to be." And he said, "You're not having one." He saw me coming. That's where the cyclotron went, into the old bunker. And Paula Pitt, who was the head of our foundation, Peter Mack, is very fortunate to have a great group of philanthropists who support us. And Paula was one of the great organisers of that, and she's been a great friend to our department. We also had great support from the maker of that scanner, Gerd Muller, who was one of the giants of PET physics, I think. We often forget the debt that we owe to him for iterative reconstruction and 3D reconstruction in PET. He was really a pioneer in that area. We also were very strongly supported. My idiotic suggestion to GE that they give us a PET scanner was really facilitated by Peter Leaney, who was salesman par excellence. He was a fantastic guy. And had a great team, very pragmatic. You wouldn't see this as a service in any service manual anywhere in the world. Getting your hammer out on a PET scanner, but one of the bolts had sheared, and Peter fixed it for us. This is day one in the PET centre, and David and Megan sitting there. Always had windows in the department. I always think that's a great thing to have. And I was really clever when I was young. I could read these scans. I don't know how, but that was the first scan that we ever did. It was a patient with lung cancer, and they had a new nodule in the left lung on the background of previous radiotherapy for treatment in the right lung down the bottom there. But the really important thing was we found a lymph node in the neck. And with ultrasound, it was biopsied and proven that this patient had metastatic cancer, not a second cancer. So it had a really high impact from the very first scan that we did. And over the next years, we went to collecting more information. We decided that if we were going to make PET cost effective, we had to identify cost savings, improve non-invasive diagnosis, allowing more appropriate selection of patients for expensive and morbid invasive procedures, detection of unrecognised metastatic disease, which would prevent futile, expensive and toxic attempts at local cure. The recognition of false positive anatomical abnormalities. We often see lumps in the adrenal or liver lesions, and we don't know whether they're real or not. They could prevent unnecessary procedures and prevent patients entering, or that would otherwise prevent patients having curative treatment. And the early assessment of therapeutic response can allow a change of therapy in non-responders, again, saving cost and the patient the morbidity of a therapy that's not necessary. And we went about this in a prospective way to collect definition of pre-PET stage and the treatment plan that the doctors were going to embark on the basis of everything they knew up to the time that they did the PET scan. And we recorded then the post-PET stage and the treatment plan, and we followed them up, and we looked at, and we had a schema that we called high impact, a change in treatment modality or intent, so from surgery to radiotherapy or from palliative to curative treatment. A medium impact was where you changed not the intent or the modality, but the delivery. So you might have altered a radiation treatment field to include disease that you hadn't previously recognised. Some people would say that's a high impact because otherwise the patient was going to die because you didn't treat their disease. But still, it was a convenient way of doing it. Low impact was where the treatment plan before the PET was the same and seemed to be appropriate after the PET scan. And a lot of clinicians said, well, the PET was actually high impact for me because I really wasn't sure that I was doing the right thing. But the reality was that they would have got the right treatment anyway, even if without the PET scan. And then the last and probably most useful group was a no impact. In those days, if we couldn't independently verify a PET finding, we allowed the clinician to ignore it. We found pretty quickly that that was wrong because PET was right the vast majority of the time, and they should have been acting on them. But in those days, we didn't know that. This was the first study we did, and we published about 5 years after we started our program. Absolutely shocking. And these data were collected by a radiation oncologist, not by us. They independently verified the results. Changed the management in close to, or should have changed the management in close to 70% of patients. A recurring theme was that the more advanced the disease, the more likely you were to find additional sites of disease. Bayes' theorem, pre-test probability affects post-test probability of disease. So in patients with locally advanced disease, a quarter of them had distant metastatic disease. And we did this in disease after disease. This is just a short list. High management change, the vast majority of them followed up, validated by clinical progression, biopsy, and so forth. How did we know we were right? We didn't biopsy everyone. We couldn't biopsy every site. The best validation of a diagnostic test is its ability to stratify prognosis. And we did this very robustly across a whole range of diseases. This is, again, just lung cancer. And the diagnostic test is only going to tell you about prognosis early on, because that's a function of burden of disease. What happens at the end is really more dependent on the therapies we give. And unfortunately, at that time, and still, most of our therapies aren't very good. So if you can't cure them with surgery, you can't cure them. And eventually the outcomes start to come together because patients die. So the other way to look at it is to look at cohorts getting the same therapy in the same institution with the same equipment, the same doctors who had PET and who didn't have PET. This is in esophageal cancer. We showed a significant improvement in survival of patients who got PET compared to those who didn't. And problem is, it's not a randomised controlled trial. It was just a retrospective study, but nevertheless, there it is. And if we look at the graph on the right, we see that it works equally well if you have curative or palliative treatment. The curatives do better because you take out the patients who couldn't be cured. It's called the Will Rogers phenomenon. But the palliative ones do better because you better select those patients, you give them treatment earlier, you better direct their palliative care in those patients. More importantly, when you've treated someone, you've got a lump and you suspected that they've relapsed, if we can identify those who have post-surgical or post-radiotherapy change rather than residual disease, and you can observe those patients and they do well, that's a fantastic outcome because you've spent nothing, you've given them no toxicity. It's an unimpeachable win-win. And Rob Ware, working with us, showed that very beautifully, and that the patients who did have disease, unfortunately, again, the therapies weren't terribly good at salvaging them, but nevertheless, very powerful stratification, and the clinicians got it. When we started using PET for lymphoma, we'd been one of the gallium centres of the world. We did gallium on everyone with lymphoma, and year on year it had been growing until we got PET, and then some of the clinicians changed over immediately to using it. And then we did a study in 2000 which directly compared them. And that's why the numbers of gallium went up again, because we were doing a head-to-head comparison. And as soon as they had the head-to-head comparison, we analysed it. What happened to gallium? It disappeared. We stopped. Can't remember when we last did a gallium-67 scan in Peter Mac, and you see PET continue to grow and it'd be off the chart now. And that was happening across the board. Our nuclear medicine, which had been growing year on year, started to flatten out. PET started to continue. And this was before we had any funding for PET. It was certainly a bold beginning for us. But we were running out of money. I had to shut down my nuclear cardiology practice to put in a second PET scanner because our waiting list was too long and the clinicians were complaining about the access to an urgent scan, which 5 years ago, before then, they hadn't believed that they needed at all. We had some innovative ways of raising money. These were actually for apartments, but I thought it was quite amusing to have the for sale sign on Peter Mac at the time because I was bankrupting the system. And so I wrote off to Medicare Services Advisory Committee trying to seek funding for PET scanning. And a friend of mine, Ken Miles, also did an application. We sent it off, and we thought we'd showed them the light, the path that they could follow. They just kept on walking. They didn't believe the data that we had, and they suggested that, in fact, that there was no evidence that PET was effective. We challenged that. I was constrained by a confidentiality agreement that my committee, which is a scientific committee, did find that it was safe and clinically effective in all of the indications which we'd evaluated, but we felt that there was insufficient evidence to warrant unrestricted funding for the whole of oncologic indications, that more data was required in the areas that we hadn't looked at because there was a less strong evidence base. But they took the lack of clinical evidence from the end of our sentence and put it at the beginning as a justification for not funding PET. And Rob Ware, who knew that conclusion had to be inconsistent with what I thought and what most of the committee thought. He fought a very valiant battle, including in the press and in the literature. And this was a commentary by the editor of the Australian Medical Journal, "The professional disquiet will arise when expert opinions proffered in a committee are not reflected in the final outcome of a health technology evaluation." And Rob's been really, as I said, a great supporter of our political push for PET. And one of the outcomes of that was to organise a Senate committee, which was held in 2007. I went and tried to preach to the politicians at the time that PET was really a great thing, but we fell on deaf ears at times. I particularly like this quote from Mark Twain. I'm sure it's run by people who really mean it. Anyway, out of the committee, I was able to get a disclaimer. That's the one outcome. I was able to perhaps resurrect my reputation, because most of my colleagues said, "How could you have been on a committee that found that there was insufficient evidence of PET? We've read your papers, we've heard you speak. You're a passionate supporter of PET, and yet your committee says that there's no evidence." Well, I got my name taken off the report. Patients actually got it really quickly. We have a questionnaire that patients have to fill in. Have you ever had problems with a PET scan? No. And this patient got it completely. This is my 2-year check. If it's clear, I will not have another scan for 12 months. They understood the prognostic significance of a negative PET scan, so don't miss anything. We try not to. One of the responses to one of Rob's many forays into the press supporting PET was to have a readers' poll on whether PET scans should be available under Medicare for all causes of cancer. Overwhelmingly, the population, a small sample nevertheless, said yes, it should be. But we still don't have that in Australia. Today's question was, is a mega taxi rank in the city a good idea? It was also overwhelmingly supported. And we do have a mega taxi rank in Melbourne now. We don't have PET funding. So one of the things we did get out of this MEMSAC review was a data collection process. That was great. And they spent lots of money. They rolled out PET into a number of new centres. We collected data in a number of diseases, this colorectal data. It took 10 years and several $1 million to prove what we'd already shown and others had already shown, that the PET makes a big impact on management. So it was like climbing a hill and finding the Safeway trolley there. Someone's already been there before. Nevertheless, we did make some progress. And one of those was to give us a little bit of money. Most of it actually came from our philanthropists who helped us to buy one of the first PET CTs in the world. I think Rich had the third PET scanner at Johns Hopkins. We had the fourth, Discovery LS, one of the GE scanners. This was a revolution for us. And everyone, at least I spoke to in those days, said, "You're crazy. Why would you put a very expensive CT scanner on a PET scanner that can only do 10 or 15 cases a day?" Well, the reason was that you could go from 6 to 15 cases a day, and it fundamentally changed the clinical perspective of this modality. This wasn't particularly a new idea, but it'd been around since the early days of rectilinear scanners, where they just put a rectilinear scanner on top of an X-ray. That's the first fusion image, I guess, and my friends Thomas Bayer and David Townsend, who actually physically put these together in the first PET CT scanner called the ART scanner. They're great guys. We did a fantastic German beer and sausages tour. If you want to find out about all the varieties of sausages in Germany, go with Thomas Bayer. He knows them inside out, from the little Nürnbergers to the great Bratwurst. They had a great idea, and they had it at the right time. Even better idea, but at the wrong time, was Dave Kuhl, who really was the father of tomographic imaging and hybrid imaging. This paper from 1966 described the use of transmission scanning linking emission scanning to anatomical data. I thought I'd invented it when I used to do photoshopping. This is an Irish patient number 131, his first study. He came to visit his daughter and he had a collapsed lung, and we didn't know where his cancer was. We did a PET scan which showed it was just at the origin of his right main bronchus. And I took Photoshop and I superimposed his PET scan on his CT. And I suggested to GE, maybe you should make me a combined scanner where I could do this instead of using the neck-top computer. We could use it in a conventional way. And they told me, we can't sell PET scanners. No one would ever buy a PET CT scanner. Well, we did. And they did. And it changed the face of cancer imaging. We could localise nodes and plan the biopsy of them by endoscopic means. We could see tumours within areas of collapsed lung and identify where to treat them radiologically. And that saved time, money and lives. We went back and revisited all the data that we'd collected in standalone PET. And again, the power is in the ability to stratify otherwise indistinguishable patients. Took 100 patients with stage 1 or 2 disease, which is curable. These patients all would have got curative treatment. The PET scan showed that, in fact, there were patients who had advanced disease, and still the PET scan stratified their outcome in a way that the conventional imaging didn't. Again, the same finding that Rob had made was just as powerfully shown by PET-CT, that patients who'd had a complete metabolic response to radiotherapy in head and neck cancer had an excellent survival, and those who had not were not always salvaged. And that changed clinical practice. For us 10 years ago, we stopped doing routine neck dissections in people with residual masses if they had a negative PET scan. New England Journal published a paper last year finding the same things and said, we don't think you need to do radical neck dissections anymore if you've got a negative PET scan. We'd published it in 2001 and again in 2007, and conveniently they forgot to reference us somehow. We also found in cervical cancer, after chemoradiation, if a patient had a complete metabolic response, their 5-year survival was 90%. And none of those cases were picked up by routine surveillance, which involved 3 monthly vaginal examination and regular CTs. Patients who didn't have a complete metabolic response, unfortunately, we couldn't salvage them. And they're a group that we have to research, we have to understand and develop new therapies for. Of course, this is a growth industry because it is so powerful. Year on year, if this was a business, you'd be in it. Every year, those graphs have been increasing, and this year we'll do over 8,500 PET scans here at Peter Mac. And that's created some stress, and my techs will forgive this one because they know that I'm always saying, oh, do you think you could put another one in, Julia? They do, they're fantastic. And my motto is Nike medicine, just do it. If things seem under control, you're not going fast enough. We're always going fast enough. And I think that this should be the way that PET goes, and Michael's going to talk more about this. These are 2 bone scans. Oops, what did I do there? Turned off the screen, yeah. But they're not really the same, are they? Look at the detail in the cervical spine there, and this one's a fully 3-dimensional scan. And Michael's going to talk to you more about PET perhaps being the future of all nuclear medicine. But that really wasn't new either. We'd known since the 1960s that the best tracer we had for bones was fluoride. It was way better than technetium, anything that we had. Then, 2003, being a crazy man, I wrote to our association and said, maybe we should just substitute where we can PET for nuclear medicine. There's already an item number. This is a better test, and I think we could probably do it for the same price. They told me I was crazy. We want to preserve the Medicare schedule. I've taken the president's name off the bottom there to protect his identity. But it's going to be a slow process, I'm sure. So sometimes I felt like I've climbed to the top of the tree and it's really got me nowhere. I think we just push on though. And we pushed on in areas that I think are really important, areas where FDG doesn't answer all our questions, like the brain. We set up fluoroethyltyrosine imaging here, did a study, and now that's routinely made by Cyclotech and shipped to many centres around Australia, to ourselves, they make it for us, and also in New Zealand, widely used, because contrast matters. Some breast cancers have low FDG avidity, so we needed a tracer to find them. Fluorocholine fit the bill, and also for low-grade prostate cancer. Neuroendocrine tumours, the topic of the next session. Again, we introduced gallium octreotate scanning here. This was an expensive and inconvenient test. This was a very accurate and much less expensive test. And really led to a whole new group of studies that we do that Michael will show you. And again, the important thing about these studies is not that they find more lumps. They impact management. That's what's important. And Michael showed very nicely that we change management in 47% of patients. And the next evolution, again, something that will be presented in more detail at the Theranostics World Congress, is the use of this to identify tiny metastases and the primaries in patients with prostate cancer. We've moved beyond lumpology to imaging biology. This is work with Grant MacArthur with targeted therapy. Within days of starting the targeted therapy, turned off metabolism well before tumours shrank. With new agents like crizotinib, this is a mutation that's present in only 4% of lung cancers. You can never do a large clinical randomised control trial in that group of patients. We knew with patient one this was an effective therapy. How fabulous was that for the patient and for the development of that drug, which is now routinely approved. And to be able to see in patients who don't have measurable disease, the response to therapy is fabulous for them and for us to know that this is working. Some of biological characterisation involves looking at more than one aspect, and this was some of our early experience with Lester Peters and Danny Rishin in head and neck cancer. Patient with tonsillar cancer with a lymph node. There's 2 lumps there. You have to believe me, I'm a doctor. And I used to read PET scans when they didn't have CTs as localisation. That's a tonsillar cancer and a lymph node. When we did hypoxia imaging, and it's great to have Uwe Ackermann here from the Austin, we sourced the F-MISO from their group to help us do this study. Only one of those sites were hypoxic, and we know that hypoxia makes cells resistant to radiation. This patient got radiotherapy, and we could see the future. The tonsillar tumour went away, the lymph node stayed. Prognostic ability from a molecular imaging signal. In neuroendocrine tumours, if we're doing the lumpology paradigm, FDG is a lousy tracer in patients with low-grade neuroendocrine tumours. We see lots of tumours on the GAT8 scan. We see none on the FDG scan. But if we look at the other end of the spectrum, patients with aggressive disease, they use glucose and they lose the receptor. So GAT8's a lousy scan on the lumpology paradigm, but they're both telling us something fundamentally different about those two populations of patients. And most importantly, the GAT8 tells us about a therapeutic target, and that's the topic of the Theranostics World Congress. And this concept, and this is something I wrote for Lancet Oncology in a commission, of whether we can afford modern medicine in the West. And my argument is that advanced imaging, we can't afford not to use it, because it provides the inextricable link between the genomic changes that drive cancer and the lump that we see at the end of the process. And in the same way that H&E pathology tells us about the morphology of cancer, but nothing about the biology, molecular imaging comes back a step at a macroscopic and whole body scale to tell us about what's driving the cancer in the same way that molecular pathology does it. And a lot of the work that we're doing in the department is about joining the dots between the genomic changes and the lump that we get at the end. So we have an idea of benched or bedside to bench and back research through human imaging, preclinical imaging. I've got a preclinical imaging facility underpinned by radiopharmacy to develop new radiopharmaceuticals, to test them in animals and to extrapolate them into humans, to work with industry and academic colleagues to develop new agents like this MEL50 melanin binding agent we did with ANSTO as part of the CRC, and with Bio21, a new zirconium labelled monoclonal antibody directed against a therapeutic target. Fabulous opportunity for translation into the clinic. And at the same time, that's my lab there. They like to have a party every now and again. So that's them sitting around one of the restaurants here in Parkville. That's my lab before it was occupied. But we've got into doing genomics to look at the genomic landscape of diseases like pheochromocytoma, Merkel cell, and neuroendocrine tumours, and to start to look at what are the drivers of that heterogeneity. These are, again, multiple primary paragangliomas, 3 seen on the Gattate scan, 4 seen on the FDG. So what was it about that one that we didn't see? We did sectioning of the tumours that were resected, and even though they have exactly the same primary driver, they all differ slightly. They've all developed their own mutations, and that affects their behaviour. And one of them is a gene that affects somatostatin receptor expression. And we're able then to compare these tumours with other tumours in other patients. It's been a fantastic journey. It's been supported by a fantastic team of clinicians and technologists and chemists and radiopharmacists, some of whom are here and some of whom have gone. Very pleased to see Val here. She kept the nuclear medicine department running when I was preoccupied by PET and did a fantastic job with that. David, Peter Yu and Peter Roselt, fantastic group of clinicians that I have. Even though there's more of them there, I still don't get to run at lunchtime. It's really a bugger. But nevertheless, it's a great team to have. Some of the people on the right there are my French Legion, French Foreign Legion, who've come to train in Peter Mac with the méthode Hicks, as we call it, Pierre Hicks, and this is in a cave in Lyon, and Laura's here. Very pleased to have her. We've also had fantastic collaborators, both locally and internationally. These are just some of them, Philip Elsinger and Oliver Niels, and again, some of my French colleagues. Cyclotech team have been fabulous. Bio21 preclinical imaging team been fabulous. The TRL won the wooden spoon on the what's it called? The hunt for, what do they call those things? Where you go hunting things around the city. No, I don't know. Anyway, we lost. We won the wooden spoon for it. Cullinan, who runs our preclinical thing. And, you know, I've got a lot of the accolades for this, but really it's only because of the team who are behind us. And I've had a most fantastic time. I've met Nobel laureates. It's really been a fantastic journey. I even got to be on the book show to share my love of literature with the Melbourne public. And you can see from some of my quotes, I'm a bit of a hackneyed philosopher as well. We have always the recognition that behind all the people that work in this place are a team who support them, the families, the children. This is a Christmas barbecue at my place. It's always a great occasion. They're the support team, and particularly to my family who've really put up with me being an absentee father for a lot of the last 20 years. So thank you to them.